So GLP-1 or glucagon-like peptide 1 is what that stands for. It was first discovered in the 1970s, and it wasn't until the 1980s to 1990s that we started to understand its role in both insulin control and food intake. So in 2005, Maccia was our first GLP-1 FDA approved for diabetes. And then in 2014 was the first medication for obesity that was approved. And then we started getting some more cardiovascular data in both 2016 in diabetes and 2023 for just obesity. So how do these medications work? Well, glucagon-like peptide, like I said, is a hormone naturally found in our body. And so when we use medications, we're just increasing the natural levels of this hormone. And basically what it does is it helps our pancreas release insulin in response to food. So that means the medicines do not cause low blood sugar because they only work when we eat, as far as the insulin release. They stop the inappropriate release of sugar from the liver. So sometimes patients with type 2 diabetes, their liver will release sugar when it doesn't need to. So it helps control that. And then it slows the emptying of our stomach. Right? So we feel fuller for longer, the food sits there for a longer period of time. And then it has this nice little communication with our brain that tells us that we're satisfied or that we're full, that what we ate, we don't need to eat anymore. And it helps control what we call food noise, which is basically that obsession over thinking about food, that wanting, craving certain things, usually things we shouldn't eat, even when we're not hungry. So these medications have been shown to significantly decrease that kind of cravings and food noise. There's a lot of names out there, right? A lot of them are the same thing, so I wanted to kind of clear up the confusion. So semaglutide is just the drug name, right? It's the actual product. We call it the generic name. Ozempic and Rybelsus are the same thing, right? One is an injection, Ozempic's an injection, Rybelsus is a tablet, but both of these are sold only for diabetes, okay? So the insurance companies have gotten a lot stricter, and you won't be able to get these products unless you actually have diabetes. But Wegovy, both the injection and now the Wegovy tablets that were recently approved, are all products that are sold for obesity or for prevention of secondary heart problems. Tirzepatide is the same thing as Mounjaro, which is the same thing as Zepbound, right? So tirzepatide is just the drug name. Mounjaro is sold for diabetes, and Zepbound is sold for obesity and sleep apnea. I'm going to talk about that a little bit more later. All right, so how well do these drugs work in weight loss? Well, the answer is pretty good. Wegovy, the injection, gives us about a 15% weight loss at the highest dose, which is the 2.4 milligrams. Wegovy tablets, which again were recently approved, at the 25 milligram, which is the highest dose, gives us about a 13.5% weight loss, so that's what we saw in clinical trials. And then Zepbound gives us a 15% reduction at the 5 milligram dose, which is the second dose, and up to a 21 to 25% reduction with the highest dose, which is the 15 milligrams. Wegovy and Zepbound, both the injections, have gone head-to-head in clinical trial. Zepbound has won, okay? It's clearly a better product, and probably because it's not only a GLP-1, but it's also a GIP agonist. So it works in two different ways, it works on two different hormones in the body, and so it's clearly a little bit better than the Wegovy. All right, so we're here to talk about the heart, though. So what can these medications do for our heart? Well, the FDA requires that all diabetic medications undergo kind of a safety data trial. And what basically the goal is to show that they don't harm the heart, right? But what they found was that there was a benefit. So these are all of the diabetic trials that show benefit with the heart. We'll talk about the Wegovy trial later. But what do we talk about? We throw out these fancy terms, cardiovascular risk reduction. What does that actually mean? Well, in the clinical trials, when we say that it reduces our cardiovascular risk, what we're talking about is death from heart causes, right? We die because of something because of our heart. Non-fatal or did not die due to a heart attack. So a heart attack that doesn't kill us or a stroke that doesn't kill us. What we look at in clinical trials, we group those things together, mostly. Sometimes we break them apart as well, but the outcome kind of looks at all three of those things. So I believe that understanding what the data tells us is important, even as patients. So I always like to talk with my patients about what does the clinical trial show us, who was in that clinical trial, how can we expand that information to us. So the SUSTAIN trial was Ozempic versus just kind of usual care of patients with diabetes who did have cardiovascular disease already. This trial was about 2 years long and had about 3,000 patients in it. And it found a 26% relative risk reduction in heart attack, stroke, or death, or an absolute risk reduction of 2.3%. And so what that means is, there's two different ways to report this trial, this data, right? Relative risk reduction, which is a proportion. So the way they calculate this is basically that 8.9% of people in the trial, in the placebo group essentially, had a heart attack, stroke, or died, versus the 6.6% of people that were taking the Ozempic. And so they do a little math to find a proportion. It's basically 8.9 minus 6.8 divided by 8.9, which gives us 26%. Relative risk reduction is a nicer way of reporting the data, basically, right? It looks better, right? So this is what the drug companies use to report on their commercials, right? It sounds better, 26% risk reduction. But what we really care about with clinicians is we look at both. And so we actually also want to know is, well, what is the absolute risk reduction? What's the absolute difference between these two groups? And so in this trial, it's 2.3%, which is really quite good over a 2-year time frame, right? So that risk reduction will increase the longer someone's on that medication. Then we look at the SURPASS CVOT trial, which was Mounjaro versus Trulicity. So Trulicity is another GLP-1. We're not going to talk about Trulicity much today. It's effective, but not nearly as effective as the Mounjaro or the Ozempic. So basically, Trulicity had already been shown to reduce our risk of heart attack and stroke. So it went head-to-head with Mounjaro and basically just found that it was just as good as Mounjaro was just as good as Trulicity at lowering our cardiovascular risk. And then we turn to our SELECT trial, which was not in diabetic patients. So this were patients, they had to have a BMI over 27, age 45 and up. Unfortunately, this trial was 72% male, but those weight loss trials that I talked about before, they actually were about 70% female. So that's really very good for a clinical trial and female representation. But unfortunately, this one was more males. The trial was about 3 years long. And again, these patients did not have diabetes, and they had to have already had cardiovascular disease. So they had to have already had a heart attack, a stroke, or symptomatic peripheral arterial disease. And unfortunately, this is important because our insurance is going to look at that criteria very closely. And so insurances, when looking at potentially covering Wegovy, they're going to ask, have you had a heart attack, have you had a stroke, or do you have symptomatic peripheral arterial disease? And so for the cardiovascular indication, we can only get it approved most of the time if those things have happened. So what we found was a 20% relative risk reduction in heart attack, stroke, or death from cardiovascular causes, or a 1.5 absolute risk reduction. All right, so we have a lot of other good purposes for using these medications. They help improve. Both both Wegovy and Zepbound have been found to improve symptoms and decrease hospitalization in patients who have heart failure, and that's both in people who have what we call a reduced ejection fraction or a decreased pumping function, or preserved ejection fraction. Unfortunately, this is not an FDA indication, so we can't get insurance coverage for this, but there is a lot of benefit in patients who have congestive heart failure. All right, our other indication is for sleep apnea, and this is Zepbound. So Zepbound was studied apnea index, which basically is just the amount of times you either stop breathing or have shallow breathing within in an hour. Okay, so this is just a score that tells us sort of the severity of your sleep apnea. And so that you have, in order to get into a trial, you have to have an AHI over 15. And again, most of the insurances stick with this strict criteria when approving. We've gotten a few approved that were less than 15, but mostly it's above 15. They studies at now 10 milligrams versus the 15 milligrams. Patients were on a CPAP, did not have to be on a CPAP machine. Some were, some were not. And basically we saw an improvement in sleep apnea severity, so a decrease in their AHI by about 50%. So very, very effective. And we also saw an improvement in blood pressure and weight loss, obviously, in the trial. All right, all medications have side effects. Even as a pharmacist, we all are not naive to think that nothing can go wrong. So we do have risks with these medications. The most common, because again, that hormone, they're working in the gut mostly. So they're mostly side effects that are GI related. So nausea, vomiting, diarrhea, acid reflux, constipation. These are all the most common side effects. They can be somewhat avoided, not all. But for example, nausea can be improved by eating a little something, right? Keeping a little bit of something on your stomach helps improve the nausea, as opposed to being like, oh, I'm so nauseous, I don't eat food for 16 hours, right? Vomiting, if we don't overeat, if we listen to those signals that are sending to our brain that say, hey, I'm full, that can help avoid that. Diarrhea tends to be triggered by fatty or greasy foods, so if we avoid the fast food line and the fried foods and things like that, that should help. Now, a lot of these symptoms or side effects are self-limiting, meaning they will go away on their own over time. So you may get a bout or two of diarrhea and they kind of go away. Obviously, if it's something that persists for quite a period of time, then we would want to stop the medication. Acid reflux, again, just avoid overeating. Constipation is a dose dependent, so the higher the dose, the more likely you're going to get constipation. And that's because it's slowing everything down, right? Slowing the emptying of the food from the stomach, so everything gets backed up. You're eating a little bit less, so your bowels are moving a little bit slower. We can back off on the dose to help with this. We can also use a few days of something very gentle, like Miralax or something, or Benefiber, I found has been pretty helpful if you take for a few days to get things moving a little bit. Who shouldn't use a GLP-1? So it does have a contraindication for people who have a personal or family history of medullary thyroid carcinoma or multiple endocrine neoplasia syndrome type 2. These are really very rare thyroid cancers and disorders. We only have ever seen them in rats. Okay, so we've never seen them in humans, but we do not use it in people who have a personal or family history of these things. If you're pregnant or breastfeeding, there's no studies in pregnant patients, so we do not use that medication. And we also want to make sure if you are of childbearing age and on these medications, that if you are on an oral birth control, the absorption can be changed with these medications. So you really should use kind of two methods, one being a barrier or condom. And we recommend that if you do are going to plan to become pregnant, you stop the medication 2 weeks before you start trying. And obviously we wouldn't use it if you were allergic to any of the components. We use it in caution with patients with chronic GI issues, so if you have chronic diarrhea, chronic constipation, colitis, things like that could become kind of unclear what the GI issues are from. It doesn't mean we can't. It just means we should sit down and have a conversation about it before starting. Gastroparesis, that's when your stomach doesn't move things as well. Of course, like we said, that it explodes. So that's a little bit of an iffy that one makes me a little uncomfortable to use. History of pancreatitis and gallstones. There's a slight increased risk of pancreatitis and gallstones with this class of medication. So again, it's not that we can't use it, but we want to have a conversation about the risks and benefits. There were some cases of pancreatitis in the clinical trials, but patients who had a history of pancreatitis were excluded. So if you have a history, we just can't really tell you whether your risk is increased or not because they weren't studied in the trial. We kind of already talked about this already, tips for decreasing side effects. All right, my least favorite question of all, to answer for any drug is how long do I need to take this for? Well, unfortunately, the answer is looking like a long time. What we're finding is that when we stop these medications, the benefits go away. All right, they don't go away right away, but a recent kind of what we call meta-analysis or a study of several trials looked at, saw that basically patients were gaining about a pound a month back, and at the 2-year mark, all of the benefit was gone. Their weight was pretty much back to baseline. Their blood sugar was back to where it was, their cholesterol was back to where it was, blood pressure, which had been improved, is now back to where it was. So we're losing those benefits by year 2. Then we also have a trial called the Step 4 trial where everyone got Wegovy, highest dose for 20 weeks. They lost about 10% of their body weight. Then they split the group. Half got Wegovy, half got placebo for another 48 weeks. The Wegovy group lost another 8%, and the placebo group gained about 6.9%. So they gained back about 3/4 of their weight. It's not to say that this will happen to every single person that takes a GLP-1 and stops it, but it's not looking great. It looks like the benefit of the medicine, we have to continue to take the medicine. All right, another concern that we do have with these medicines is muscle loss. So we know that people who are overweight or have obesity, they have a higher muscle mass to begin with, okay? And we lose muscle mass when we lose weight, regardless of how we lose it. Whether we diet it away, we exercise it away, or we take any form of medication. We know that we're going to lose some muscle mass. We see a range of 20 to 50% of the weight loss that we see with GLP-1s is lean mass. What we mean by lean mass is it's not just muscle, but it's muscle, organs, bones, fluid. What we don't really know, it was not clear because in the trials, they only study a small subset of people and their muscle mass loss. And so what we don't really fully understand is it a decline in muscle quality, like the strength and function of our muscle, or is it just the amount that we're losing? What we're thinking is that evidence suggests that the quality maybe doesn't change, and maybe we're just losing the quantity, the amount. But what's important to note is that muscle loss decreases our resting energy expenditure more than 3 times that of fat loss. Our resting energy expenditure is basically the energy we burn by doing literally nothing, okay? We want to keep that number high. If we want to lose weight, we need to make sure that our output, our energy expenditure is greater than our input, right? And one of the easiest ways to do that is burning calories by literally sitting there, right? So we want to keep that high, and we keep that high by having muscle mass, right? Having lean body mass. Therefore, the goal should always be to maintain or increase our muscle mass. And this should be the goal regardless of whether we're doing this with medication or not, but with the medication it's even more important. And that's where resistance exercise comes into play, and we'll talk about that a little bit more. There, of course, the rare risk of causing something called sarcopenia, which is kind of a muscle wasting, kind of rapid decline in health kind of syndrome. But basically what we find is if we do this the healthy way, where we lose a small amount of weight, 1 or 2 pounds per week, which is what we usually want people to do, right? I don't want you to come into my office and say I lost 50 pounds this month. That wouldn't actually make me very happy. I'd be quite concerned. But we can kind of avoid some of the stuff and we just have this slow, healthy weight loss. So diet and exercise. These medicines have to be used with diet and exercise. This is how they were studied. This is how we know they work the best. And they're not going to work very well if we can't change, if we don't try to change some of these things, right? So because we're worried about muscle loss, we want to make sure that we eat enough protein. So protein in the forms of fish, nuts, lentils, seeds, beans, chicken, turkey, those lean meats. I'm not a nutritionist, okay, I won't pretend to be, but generally my recommendation to most people is that we try to aim for about 1 gram of protein per pound of body weight, okay? And resistance training. So we should be doing this 2 or 3 days a week. And what I mean by resistance training is something, sometimes we refer to it as weight training, lifting weights. It doesn't have to be that though, right? It can be body weight, it can be weights, it can be resistance bands, but something that's going against our muscle, okay? And it doesn't have to be heavy, right? I'm not asking you to go back squat 250 pounds, right? We're just something that's providing some resistance to our muscles, whether that's air squats or lunges, push-ups to the wall, light overhead. The American Heart Association has a really great chart on their website of recommendations for just kind of general exercises that we can do that hit each muscle group, okay? So the biggest issue with these medicines, and I'll speed up because we're running out of time, they're really expensive, unfortunately. But we have seen a reduction in costs come down, but they're still pricey. Coverage varies from insurance, right? Medicare is not allowed to cover these medicines for obesity. So Medicare will only cover it if you have coronary artery disease or if you have OSA, okay? Medicaid does cover now for obesity. They went back and forth, but they will cover for obesity and those other things. There are copay cards from the manufacturer, but there's limitations. So they only take off about $100 a month. So if your copay is $600, that doesn't help that much. So there's unfortunate limitations. There are direct-to-consumer cash price options. They range from $150 to about $450 a month, depending on which product and which dose. Unfortunately, the lower doses are the lower cost is the lower doses that don't work as well. So the Wegovy tablets do start at $150, but those first 2 doses, I'm sorry, they don't work very well. And so the higher doses, the ones that are effective, are back up to about $350 a month. So they're still costly. Hopefully that will improve. But we'll sort of wait and see. There is some competition between the 2 drug companies, so that's good, always good. All right, who can we trust? Read the fine print, okay? There's lots of commercials out there, right? Roe and Hims and Hers. And Roe requires a subscription, okay? If you have a doctor that's willing to prescribe this medicine for you, it's probably cheaper to go with the cash price option through your doctor than signing up for that company because they're going to charge you $45 a month. Hims and Hers compounds, so please do not use Hims and Hers. They're using compounded semaglutide, which we absolutely do not recommend. We cannot speak to the safety or if it works. All right, so in summary, these are very, very effective medications. And we know that they improve a lot of different heart conditions. Like all medications, they come with side effects. They come with risks, so it's always important to talk with your doctor or your pharmacist about whether it's a good choice for you. And of course, cost is still one of the biggest hurdles. And we're almost out of time, but I will take some questions, and if not, I'll be in that back little corner afterwards. Any questions you guys have?
Is the cardiovascular risk reduction or help with that, is it directly related to weight loss, or is it on its own without weight loss you can still have cardiovascular benefit?
Yeah, that's a fantastic question. So we do think that it goes beyond the weight loss. The weight loss is certainly beneficial, but we do think that there's something with the medicine, whether it's improving blood sugar control or some other thing that we're not sure about, The people in the clinical trial, I mean, they lost some weight, right? They didn't lose nothing. So we do think that it is a benefit beyond just the weight loss that it provides.
Do you know in the clinical trial that are also having people do like the weight resistance and food modification? So I'm just curious if it's like, do you think it's like we're doing short-term cardiovascular improvement, but trading it off for increasing growth since you're seeing a decrease in that lean muscle mass, which would be more rate?
Yeah, so everyone, at least the strictly obesity trials, everyone followed like a strict diet and also had like an exercise regimen.
How do they differentiate, I guess, the benefit of the drug from those lifestyle modifications? Because if you're seeing lean muscle mass loss in like the general population from prescribing this, and that benefit is more so weight loss, but you're also seeing muscle mass loss. Is that impacting these markers that we're seeing, or?
Yeah, so because basically everyone in the trial, whether you're on a drug or not on a drug, was encouraged to do all of those same lifestyle changes. So they all had the nutrition coaching and things like that, and exercise. And they didn't know whether they were on, I mean, they probably figured it out because if you're taking something it's not working, but, they technically they were on placebo, right? And still found a greater